THYMOMA is an oncological disease. Look at this picture, shows that tumor, cancerous X-ray findings. Look at this. CT scan, and MRI findings. Look at this. Detail going on. Introduction. THYMOMA is a rare tumor originating in the thymus gland, located in the anterior parts of the midsternum. It is associated with variety of systemic syndromes and is most often found incidentally during imaging studies or investigations for associated conditions. While it is generally slow growing, thymomas can be locally invasive and have potential for metastasis. Etymology. The word thymoma originates from the Greek root thymos, meaning thymus, combined with the suffix oma, which denotes a tumor or swelling. It refers to tumor arising from the epithelial cells of the thymus glands. A definition. Thymoma is a neoplasm arising from the epithelial cells of the thymus gland. It can be benign or malignant and is classified based on its historical features and potential for invasion. Thymus are distinct from thymic carcinomas, which are more aggressive and poorly differentiated. The World Health Organization classifies thymomas into the following types based on histology. 1. Type A, composed of spindle oval epithelial cells, generally benign. 2. Type AB, a mix of type A cells and lymphocytes, typically benign. 3. Type B1 resembles normal thymic tissues with abundant lymphocytes. 4. Type B2 has a higher density of epithelial cells with prominent lymphocytes. 5. Type B3 predominantly epithelial cells, more likely to be invasive. 6. Thymic carcinoma, poorly differentiated and highly aggressive. Causes. The exact cause of thymoma is unknown, but potential factors include 1. Genetic mutations in thymic epithelial cells. 2. Immune dysregulation. 3. Environmental exposure. Example, radiation. Risk factors. 1. Age. Most common in adults age 40 to 60 years. 2. Gender. Slightly more common in males. 3. Autoimmune disorders associated with conditions like myasthenia gravis, lupus, and rheumatoid arthritis. 4. History of midsternal radiation. Complications. 1. Local inversion spread to adjacent structure like the pericardium, lungs, or great vessels. 2. Paraneoplastic syndromes, commonly myasthenia gravis, but also pure red cell aplasia and hypogammaglobulimia. 3. Metastasis. Though rare, thymus can metastasize to distinct sites. 4. Post-surgical complications. Recurrence, infections or complications from incomplete resection. Pathophysiology. The THYMOMAs arise from the epithelial cells of the thymus. The tumor's growth disturbs normal thymic architecture and function, which can interfere with immune system regulation. This dysregulation often results in autoimmune disorders. Invasive thymomas penetrate surrounding structures and may induce compressive symptoms or systemic effects due to paraneoplastic syndromes. The pathophysiology of thymoma involves several steps related to its origin, progression, and associated conditions. Here is step-by-step breakdown. 1. Origin in the thymus. 2. Genetic and molecular abnormalities. 3. Abnormal cellular proliferation. 4. Immune dysregulation. 5. Tumor microenvironment. 6. Progression and spread. 7. Clinical manifestations. Tumor growth and immune dysregulation leads to clinical symptoms including anterior midsternal mass effects, example chest pain, cough, dyspnea. Paraneoplastic syndrome, example myasthenia gravis, or systemic immune effects. Understanding these steps highlights the complexity of thymomas, their impact on immune function, and the challenges in managing both local and systemic effects. Signs and symptoms. Local symptoms: chest pain, cough, shortness of breath, superior vena cava syndrome, swelling of the face and neck, venous distension. Two systemic syndromes: fatigue, weight loss, muscle weakness associated with myasthenia gravis. Diagnosis: 1. Imaging. Chest X-ray may show an anterior midsternal mass. B. CT scan MRI defines the size, location and extent of inversion. 2. Biopsy. Fine needle aspiration or core biopsy confirm histology. 3. Laboratory tests. A. Acetylcholine receptor antibody levels for associated myasthenia gravis. B. CBC and immunoglobulin levels. 4. Pulmonary function test. Assess impact on lung function. Nursing diagnosis: 1. Ineffective breathing pattern related to compression of midsternal structures. 2. Risk for infection related to immunosuppression or treatment. 3. Acute pain related to tumor inversion. 4. Impaired physical mobility related to muscle weakness or paraneoplastic syndromes. 5. Anxiety related to diagnosis and treatment outcomes. Management. First, medical management. 1. Surgery. Thymectomy. Complete surgical removal of thymus and tumor. 2. Radiation therapy for invasive or incompletely resected tumors. 3. Chemotherapy for advanced or metastatic thymomas, example cisplatin based regimens. 4. Immunotherapy, targeted therapy for associated autoimmune disorders. Nursing management. 1. Monitor respiratory status, manage airway obstructions. To provide pain management using pharmacological and non-pharmacological methods. 3. Educate patients about post-operative care and symptoms of occurrence. 4. Assist with mobility and provide physical therapy as needed. 5. Offer psychosocial support and counseling. Treatment options: 1. Surgical resection, primary treatment for localized thymomas. Radiation therapy, adjuvant therapy post surgery or for unresistable tumors. 3. Chemotherapy used in advanced stages or metastatic disease. 4. Targeted therapy under investigation in clinical trials. Psychosocial medicine. 1. Support groups for patients and caregivers. 2. Psychological counseling to manage anxiety and depression. 3. Patient education about disease and treatment options. 4. Stress management techniques such as mindfulness and meditation. 5. Addressing body image concern post surgery. Prevention. While there are no specific preventive measures, early detection through regular health checkups and Monitoring of associated autoimmune conditions may help in early intervention. 1. Regular health checkups. 2. Management of risk factors. 3. Monitoring for autoimmune conditions. 4. Genetic counseling. In conclusion, THYMOMA, though rare, poses significant challenges due to its potential for local inversion, systemic effects, and association with autoimmune disorders. Early diagnosis and a multidisciplinary approach to treatment are essential to optimize outcomes. Advances in research are improving understanding and management strategies, offering hope for better prognosis and quality of life for affected individuals. Thank you. Have a nice day.